Hello everyone and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples listening today and in the future. My name's Marina and I'm an AOD counsellor and educator at Turning Point, and I will be facilitating today's webinar. So our webinar today is understanding and supporting the unique perspectives and contributions of workers in the alcohol, tobacco and other drugs sector with lived and living experience. This webinar is part of a series of Connect and Learn webinars designed to support AOD clinicians throughout Victoria. This webinar is part of the funding by Victorian Department of Health and hosted by us, Turning Point. We like our webinars to be as interactive as possible, so please ask questions via the Q&A function. The questions will be collated and answered by our presenters at the end. So please be aware that our webinars are recorded and are later made available on the Turning Point website. So we encourage you to stay to the end of the webinar and complete the exit survey when the QR code pops up on a slide or via email later on today. A copy of the slides will also be emailed to you. So without further ado, I'd like to introduce our presenter, Anke van der Sterren. Anke van der Sterren is the Research and Sector Capability Building Manager of the Alcohol, Tobacco and Other Drug Association, ACT. So the acronym ATODA, ATODA, the peak organisation for alcohol, tobacco and other drugs services in the ACT. So Anke is a medical anthropologist with experience in public health research and evaluation, applying mixed methods to a range of ATOD issues. This has included working in Aboriginal community-controlled academic and non-government settings, engaging collaboratively with communities experiencing complex health and social disadvantages and marginalisation. Anke is part of the Future Health Leaders program at UNSW and is undertaking a professional doctorate in applied public health. And without further ado, Anke will now introduce yourself and present. Thank you.
Great. Thank you so much, Marina. It's lovely to be here. Thank you for the invitation to present today. I'm really pleased to be here. As Marina said, I work at ATODA, the Alcohol, Tobacco and Other Drug Association in the ACT. So we're the peak organisation for drug and alcohol services here in the ACT. And for those of you who are in Victoria, you would probably be familiar with VADA, the Victorian Alcohol and Drug Association, which is our sort of equivalent peak in Victoria. So we undertake a range of policy advocacy, research and capacity building activities to support the ATOD sector here in the ACT to reduce alcohol, tobacco and other drug-related harms. And using and building the evidence base is really important to us for of course, the best practice service delivery and policy that's key to our work. And supporting the workforce development and capacity building is really a central activity for ATODA. So as part of this, we recognise that workers with lived and living experience of problematic alcohol and other drug use bring really unique perspectives to the sector and skills to their practice. And as such, I'll be talking today about some work that we've done here in the ACT around improving our understanding of the characteristics and the contributions of workers in the ATOD sector who have lived and living experience, and reflecting on how to better support this part of the workforce and to utilise their unique contributions to improve treatment and support. So I'll be referring to two pieces of work, research work that we do here at ATODA for the sector. One which is our workforce profile, and the other which is a service user satisfaction and outcomes survey. I'll be talking a little bit more about those in a moment, giving you some more background for those. But before I start, I'd also like to acknowledge the Ngunnawal people as the traditional custodians of the lands of the ACT and region where ATODA works, but I'd also like to recognise the traditional custodians of the lands from which everybody here is joining the webinar today. and also to say that ATODA recognises and continues to learn from the contributions of Aboriginal and Torres Strait Islander people to the alcohol, tobacco and other drugs sector. I'd also like to acknowledge the extraordinary work of frontline workers in the alcohol, tobacco and other drugs sector. So just to talk a little bit about what I'll be doing today, as I said, I'll be referring to data from the workforce profile to examine the characteristics of the lived and living experience workforce here in the ACT, and also looking at how these workers believe that their lived and living experience actually influences their practice. I'll briefly reflect on some of the data that we have from the recent work that we've done in the development of our service user satisfaction and outcome survey, to also explore some of the qualities that were identified by these service users as being important for the lived and living experience workforce. And I'll finish off by then reflecting on how we can use some of this information to reflect on improvements to recruitment, retention and professional development pathways, providing more supportive workplaces and also providing high quality treatment and support. So before going any further, I just want to sort of provide the kind of definitional background to what I'm talking about here in terms of lived and living experience. So, and in particular to kind of talk about how this differs from when we talk about peer workers. Now, I understand that this is a little bit that different people have kind of different definitions around this, but I just want to lay out how we understand it, so that that the kind of frames what I'm talking about today. So peer workers in this context, we're talking about those who are specifically employed by their organisation to use their lived experience to inform their work. And that's in contrast to workers with lived and living experience who may be belong to a number of different professions, but also happen to have lived and living experience of drug and alcohol use. So, of course, peer workers can be conceptualized as a component of this, but peer work is not everybody with lived and living experience in the drug and alcohol workforce. And in this data set, we're also actually talking not just about frontline workers, but also people who work as administrators or managers, who work in research and policy and other areas of AOD services. So just to sort of give you a bit of context of the drug and alcohol sector in the ACT, we have 10 services in the ACT providing specialist ATOD interventions across the entire range of evidence-based intervention types, as you can see here in the centre. We have one government provider, and then the other 9 are NGO providers. We have 2 Aboriginal and Torres Strait Islander community-controlled organisations, and then a further organisation that has an Aboriginal-specific program, which is also the peer-based organisation, CAMA, the Canberra Alliance for Harm Minimisation and Advocacy. And we've got other sort of specific groups that some services are providing for 2 youth specific organisations, and also a service that specialises in providing for services for women. So that's just a little bit of background. Also, as background, it's important to know why we're doing this work. The recently, or released about a year ago probably, the ACT Drug Strategy Action Plan 2022 to 26 identifies as one of its priority areas that the value of peer support workers and people with lived experience to reducing harms from alcohol and other drug use, and focuses on some objectives and action areas around capacity building, around developing work and networks, and around formal qualification pathways. So some of the work that I'm talking about today is important to inform what we're trying to achieve under the Drug Strategy Action Plan as well. So this is the basis of some of the data I'll be presenting today. This is the ACT ATOD Workforce Profile. It's a profile that we have been doing 3 yearly since 2006. And so in 2021, we did the 6th survey, and that's where the data for this is coming from. We have in scope for this, and this is actually quite unique. I think it might be the only sort of jurisdictional level survey of its type where both government and non-government drug and alcohol services are surveyed at the same time with the same survey, and it's across the range of treatment and harm reduction intervention types. So all of those 10 services and the programs under those 10 services are in scope for that. So in the most recent survey, as a result of that, we found that we have a total workforce of about 330 workers, which excludes the vacant positions. And then we had a response rate of 57%, where 188 workers responded to the survey from 9 organisations. And the survey measures a range of demographic and workforce characteristics, as well as looking at the wellbeing of the workforce. The 2021 survey was the first time that we included a set of questions that were specifically related to lived experience in the workforce. And so the main question, the sort of starting question that we use for that is, do you identify as having lived experience in relation to alcohol or other drug issues? And to select all that applies. So note that multiple responses were possible. This question and a number of the other questions we've used come from the National Alcohol and Other Drug Workforce Survey that has been administered by ACTA in 2019-20. So we've used those questions as as the sort of starting point, and then ask it an additional one. So, as I said, multiple responses are possible, and then this was followed with some follow-up questions about asking people whether they disclosed their lived experience in the workplace, and if not, why not? So, just to start with what we found in terms of prevalence of lived experience amongst the ATOD workforce in the ACT, 3.7% preferred not to say, and just over 35% identified that they had either personal lived experience only, or they had personal lived experience as well as some family or other lived experience. About 29% said that they had family or other lived experience only, and 32.4% said they had no lived experience. So, for the purposes of the analysis that we've done of the data, we've excluded the people who said that they prefer not to say, as well as anybody who didn't answer the question. And then we have looked at 2 different groups. So one group is the people who identified that they had any personal lived experience, which was 66 people. And we compared them to a group that said that we've called them no personal lived experience, but there was included in that the group that had some family or other lived experience, but just for the purposes of this analysis, we've classified them as no personal lived experience, and that's 115 people. So for the analysis, as I said, we've compared personal lived experience, so 66 people, to all other workers, 115, and we excluded the 7 people who did not answer or responded that they prefer not to say. We've looked at several characteristics, some demographic characteristics, workplace characteristics, work-related psychosocial factors and experiences, and wellbeing and health. And the statistical analysis we've used is chi-squared tests of of independence and independent sample t-tests to look at the differences between these two groups. So looking first at demographic characteristics, we looked, as you can see down on the left-hand side, we looked at the variables of age, gender, sexual orientation, country of birth, speaking a language other than English at home, so to look at called status for both of those, the salary range, and also highest qualifications. And what we found was that workers with personal lived experience were more likely to identify as male, to identify as LGBTIQ A+, and also to have lower than bachelor qualifications. And this is actually consistent with what we know about our service user group, where we also have a higher proportion of male to female. We have about 11% identify as LGBTIQ, and so that this is consistent with that. And also where we have about half of service users who have lower than bachelor qualifications. So this is broadly consistent with what we know about our service user group. You can also see in the salary range that although it's not significant, it does, the skewing is more towards workers with personal lived experience having lower salaries as well. Looking now at workplace characteristics, we looked at variables of time in their current position and organisation and sector. Also looked at sort of work roles around whether people had direct client contact or not, and also sort of types of roles, AOD workers versus other direct client roles, their contract type, employment status, and also hours worked. And what we found is that there was workers with personal lived experience were more likely to be working in direct client contact roles, which is perhaps not surprising, but also to more likely to work full-time and more likely to work more hours per week. I should note that for most of the differences that we found, the effect sizes were small. There's only a couple that had medium effect size that I'll show you in a moment. For work-related psychosocial factors and experiences, we looked at a number of, we used a number of scales. So the job satisfaction, professional growth, and stress scales are from the Texas Christian University Organizational Readiness for Change measure. And the burnout measure is the Sharon Melamed burnout measure that we used. The therapeutic optimism was measured using the ELSOM therapeutic optimism scale. Others are related to questions. So there were a number of statements of job satisfaction that we specifically looked at, and we also looked at practice supervision. So whether people receive practice supervision and the extent to which that practice supervision meets their needs. And then also asked about accessing professional development and then their plans to remain in their current position. So what we found was significant differences with burnout. So workers with personal lived experience were more likely to report burnout, and they were perhaps a little surprisingly also reported that they were receiving sufficient practice supervision, more likely to be receiving sufficient practice supervision, and more likely to report not experiencing challenges accessing sufficient professional development. And again, these effect sizes were small. So finally, looking at well-being and health, we looked at smoking status, and then we also looked at a number of measures of well-being. The measures of well-being there come from the health and social functioning section of the treatment outcome profile. So the physical, psychological well-being scales and the quality of life were scores out of 20, and then the overall well-being is a you add those together to get a score out of 60. And so the significant differences that we found there were with smoking status, so that workers with personal lived experience were more likely to report being a smoker, and were more likely to report lower physical and overall well-being. The effect sizes for smoking and for physical well-being were medium effect sizes, but the overall well-being is just a small effect size. We also asked for the first time, not surprisingly, in 2021, asked about the impact of COVID on well-being generally and well-being at work, but there was no reported difference in those measures between the two groups. So we also asked asked workers who had disclosed that they had personal lived experience whether they had disclosed this in their workplace. And most indicated that they had disclosed it in the workplace. So nearly 80% said that they had told colleagues or managers about their lived experience. Of those who had not disclosed, which was 14 people, half there, and note that there were multiple answers possible for this, but half indicated that they did not disclose to avoid judgment, stereotyping, or stigma, or because they had concerns for confidentiality or privacy. And 2/3 of them all said, so that clearly you can see there's an overlap there. There's some people who answered both of these. 2/3 said that they had no desire or need to discuss it, or they felt that it wasn't relevant to their job. So we also asked workers to basically a qualitative question to talk about how they felt that their lived experience with alcohol, tobacco, and other drugs had influenced their work with clients. And they gave a number of, their answers sort of provided us with insights to a number of kind of reasons for why they felt that their lived experience was either beneficial or not to their work. Most felt that it was beneficial. They felt that it gave them an understanding of their clients, a better understanding of their clients, and provided them with insights into the issues that were faced by their clients with problematic alcohol, tobacco, and other drug use, and that as a result they had greater empathy and or compassion because they understood these issues. They felt that it probably added to them having less judgmental attitudes towards clients of alcohol, tobacco, and other drug services because they sort of understood where people were coming from, and that they also recognised the stigma and discrimination faced by service users of those of their services. They particularly felt that it added value to their role, that it gave them practical knowledge and skills to assist their clients, and would help them to build trust and rapport with their clients, as well as enabling a more grounded and realistic approach to working with clients of the services. And importantly, it also had a influence on career choices and trajectories. So they would choose to go into the drug and alcohol sector because of their experiences. And probably these are probably familiar to you. You would have seen these elsewhere or have colleagues who have reflected this to you themselves. It's probably not surprising to you. But just to give you a taste of some of the things that were said by workers, this is an example of one of the responses. So this gives me an understanding of the intense grasp of addiction and the almost inability to stop an action once the craving grabs you. I fully understand guilt and shame. It has taught me that being aware of early choice making and early intervention is my best option ongoing to avoid returning to past behaviours. Choosing associations carefully is also of utmost importance. This gives me compassion for others, and I'm highly focused on creating an understanding, accepting atmosphere in my workplace. I try to build a genuine connection tailored to each client. So this reflects several of the things that I pointed out before about, having a better understanding of where people are coming from, understanding the guilt and shame that they're experiencing, and providing a compassionate, accepting atmosphere and having a genuine connection with service users. And it also refers to the influence on their practice, where they that their experiences basically taught them about being aware of what they think sort of works and doesn't work in their practice. So here's another example of my experience. My lived experience is why I work in this sector. So it's an illustration of how it's influenced their career choice. I believe that my experience has made me more thoughtful and compassionate than I would otherwise be. I'm not sure that I believe that lived experience is necessary, but it's definitely beneficial in appreciating the 2 steps forward, 1 step back patterns we often observe in people trying to change the way they use drugs and alcohol. So this is a good illustration that, perhaps lived experience isn't necessary for everybody, but it does provide additional insights and understanding to their work. It influences my practice in the ability to be non-judgmental in certain situations due to having experienced similar ones myself. It also influences my ability to assess risk in the moment because I view some aggressive behaviours as coping modes and not as a threat. It has influenced me to study and learn evidence-based approaches, as my experience will only help so much. So again, talking about how it's influenced their practice and how their ability to be non-judgmental and to be able to assess risk in the moment it has, helped their practice. Even though I may have similar experiences to some clients, I'm fully aware that their experiences may be or feel totally different to mine, and I would never try to tell anyone that I know exactly how they feel or how they should deal with situations. However, I feel having some lived experiences helped me to have a deeper level of empathy and knowledge to provide support to others. So this one's also important because there's an acknowledgement that there are different experiences that people have. So that even though they have their own particular lived experience, that this might be different to, while it does provide them with insight, it also might be different to how service users, how their clients are experiencing their alcohol and other drug use. So I'm now going to turn to the other kind of side of it, which is looking at some of the perspectives of service users. So ATODA does every 3 years, although it's been longer because of COVID since we did the last survey. But we do a 3-yearly survey of all people who are accessing specialist ACT, alcohol, tobacco and other drug services at a single point in time. We collect information through that survey on the profile of service users and also on their self-reported experiences of service access. For the survey, we've just done that. It's just been in the field. We've only just finished collecting the data for the new survey, but in the lead up to that, we undertook a quite intensive redesign process supported by the ACT Health Directorate to do this redevelopment to better reflect the experience perspectives of service users. And as part of doing that, we were basically looking at what are the themes of service user experiences that are most important to people accessing ACT, alcohol, tobacco, and other drug services. And so to do this, we did focus group discussions we did 12 of these with different groups of service users with different demographic or service using characteristics, and basically started with the very general question of, if you think about a time when you had a good experience at an alcohol, tobacco, and other drug service, what made it a good experience? And that basically opened up a conversation for people to talk about what they felt made a good experience. What we found with this was that actually in almost all of the focus group discussions that we did, a really key theme that came up repeatedly over and over again was around having access to having access to workers with lived living experience who um, they felt, had the important qualification, and they felt really that having access to workers with lived experience was really central to a good experience in a drug and alcohol service. So service users uh, were, repeatedly talking about how they appreciate having access to workers with lived experience because they felt that they could relate better to them and that they provided better support. Interestingly, so I should emphasize that the main purpose of these focus groups was not to investigate lived experience. So we didn't actually look at this in great detail, but it was just really important that having lived experience workers and access to lived experience workers was seen as being really, really critical for these service users. Um, but there were a number of things that became apparent as we were talking to people was that, for instance, service users often make assumptions about the lived and living experience status of workers. So they didn't necessarily, that they were often guessing that that workers had lived a living experience, and they were highlighting what they thought were certain qualities of workers with whom they had positive experiences, and often were making assumptions that workers with those qualities were also workers that had lived a living experience. So I'll just highlight a few of the quotes that we that came out of these focus groups. So for me personally, I'd rather have someone who's a recovering counsellor and then they've got better insight into me as opposed to some dickhead out of a book saying this is what you should do. Like, well, have you gone through what I've gone through in order for me to get there? No. Well, then how do you know how? Like, just that's why I don't bother with them much. So there were, other quotes like this or other statements like this, which were very much about, oh, the book learning is not enough, and we really want to have somebody who actually understands where we're coming from. So they don't have to have a little card that says they've been through 2 years of uni or whatever. They've they've got their own card saying, I've been on the streets and I've done my drugs and I'm trying to help people. And another person, because there's nothing worse than having to talk to someone that has absolutely no experience in what you've been through. How can you have a drug and alcohol counsellor who's never taken drugs or never really had any exposure to the hardcore side of addiction? And so, this again kind of reinforces that there was sort of a feeling that workers could not understand what service users were going through unless they'd actually walked the walk and talked the talk. I mean, one user knows another user from a mile away. I don't know. It's just a certain vibe you get from someone if they're just like an armchair counselor, or one of those people that preach at you from an armchair. So this was a sort of an illustration of how assumptions were made about whether a worker did have lived experience or not. So um, when we spoke to people, we did sort of ask, oh, do workers actually disclose their lived experience, in the therapeutic context? And mostly they said, service users sort of said, no, they don't. And then we said, well, how do you know that they have lived experience? Oh, we just know. It's just like a certain vibe. It's just, and there seem to be sort of cues that would help them to make those assumptions. And amongst those cues, they said things like, the way people dress or the way people talk or the small hints that they drop about, some certain things that they say just lets service users know that workers have lived experience. But we weren't, of course, able to test this because, we couldn't ask those workers, whether they have lived experience or not. And there were other cues that people seemed to talk about, which were mostly around how workers were behaving in terms of stigma and judgment, and making service users feel safe in the therapeutic context. So this is just a small illustration. So the doctors have a sort of underlying intellectual understanding of the issue, but not a practical. They don't need a practical. They don't need to be addicts themselves. But I mean, they'll be able to sort of talk the talk, but they say it looking down their nose at you. And so what we felt this illustrated is that while lived and living experience may be sort of identified as being really key, actually there are some very fundamental ways in which service users and service providers or workers interact that are really key to service users around things like stigma and discrimination, not being looked down upon, and not being judged, and feeling safe in the therapeutic context. So I'll just finish off by then talking a little bit about the implications for some of this data on some things that we've just been thinking about in the ACT, and in particular as they relate to the support that we now have in the Drug Strategy Action Plan to do some more work around workers with lived and living experience and the peer workforce. So importantly, I think in the sort of looking at recruitment, retention, and professional development pathways, the first thing is to acknowledge and understand the extent of lived experience in the ATOD workforce. And so this is actually relatively new. There haven't been too many surveys done where we've actually measured the ATOD workforce lived experience. We've, I think, known for a long time that there is a sector, a segment of the workforce that has lived a living experience, but we have not done much work around actually measuring that. So the survey that we've done, where we've found about a third of the workforce having personal lived experience, is consistent with some other surveys that have been done, including here in Australia, for instance, in the New South Wales workforce, for instance. And that's a significant chunk of the workforce, and I think we have to acknowledge that, and also have some understanding as to what the implication is for recruitment and retention and supporting that workforce. So in terms of recruitment and retention, and providing professional development pathways, if we think about the characteristics of the workforce that I identified before, in particular, for instance, not having as strong a background potentially in formal education, then it becomes very, very important that we're able to provide accessible and low threshold pathways into ATOD work. And that may be everything from making sure that we have some very particular qualifications around peer workers, and encouraging the peers to enter the workforce, but it may also be around providing more subsidised places into ATOD work, into different health professions, and in particular, for instance, to attain a minimum qualification in for Cert 4 in AOD. And also that we work out ways to value lived experience in professional practice, and how to support professional development around that. How do we better support workers with lived and living experience to apply their experience to evidence-based practice, and how do we support them to do that? So secondly, looking at building and maintaining supportive workplaces, we were heartened that our data seemed to show that generally workers were open about their lived and living experience and felt that they could be open. That that is excellent, but I think we have to make sure that that is true across the board, and that workers feel that they are working in non-stigmatizing, accepting and supportive workplaces, and feel that they can speak openly about their lived and living experience, and that that other workers can actually learn from that as well. There's some very particular skills that are needed in for lived and living experience workers to manage the nexus between lived experience and practice. In particular, this is true with managing vicarious trauma that may arise within practice, but also in how to, or how not to, or when to, if that's appropriate, disclose their lived experience in the client-practitioner relationship. Generally that's perhaps not an appropriate thing to do, but are there cases where it might be, or is it helpful to, I don't know, some of those cues that service users were talking about how people speak or what they speak about, that might be helpful to creating a more useful therapeutic relationship. How do you actually usefully do that? And then, as our data shows, there were some very specific wellbeing issues that potentially affect workers with lived living experience, and that we pay attention to providing appropriate wellbeing support. So in particular with our data, it was around physical wellbeing, and that there might be additional attention that we need to pay to that. And then finally, looking at the provision of high quality treatment and support. I think that there's immense value, and I think we all see that, but it's about knowing what we can do with it, the value of lived and living experience workers to providing quality service delivery. Clearly, it's important to service users that they have access to workers with lived and living experience, and that we acknowledge that workers with lived experience are really part of a service mix. But I think this last point is something that I've been thinking about in relation to the data that we collected with the Service User Satisfaction and Outcomes Survey. So learning from what's good about service user experiences of workers with lived experience. And so what I mean by that is that if service users have a perception that that they want to have access to workers with lived experience, and that there are certain qualities of workers with lived experience, how can we kind of identify what those qualities are, and how can we learn from that such that we're able to apply that across our entire workforce? So, for instance, I pointed out that in particular, not feeling judged was a really key issue for service users, and they felt that workers with lived experience were less likely to judge them. How can we actually learn from that and apply that across our entire workforce? So that's the end of what I have to say. I do want to just acknowledge the artwork that we have in our on all our slides, our branding. This is an artwork by Sterren. It's called Unspoken History Map of Pain, and you can learn more about the artwork and about the artist at that QR code. I'd also like to acknowledge that we're funded by the ACT Health Directorate, and to do this work, and my contact details are there on this slide if you'd like to contact me. I would love to talk more about this, so thank you.
Great, fantastic. Thank you so much, Anke. That was really fascinating. We've got quite a few questions that have come through, so people feel free to go into the Q&A and ask some questions. So I'm just going to read out a couple of these. And so I've got here, why do you feel people with lower education status contact your services less?
Why do I feel that people with lower education status contact this? Did I say that? I'm not sure. I don't feel that people with lower education status contact the services less.
All right.
Maybe they could give more detail or contact
Yeah.
me afterwards. Yeah, I'm not sure what was meant by that. Yeah.
We'll come back to that one.
Yeah.
And there are a couple of others. So one is, has the data tried to consider non-binary and gender diverse workers and clients, which I have responded to, but please, if you could clarify.
Yes, absolutely. So, yes, we do collect when we ask the question in the survey. We do collect that information, but the numbers are so small that we we excluded them from the data. Like, it was fewer than 5 people who identified as such. So they were removed from that particular data analysis.
Yeah, but that was actually on one of your slides as well, I noticed. So
yes, it was as a footnote. Yeah.
Okay. Then we also have, has anyone ever surveyed, this is a really interesting question, surveyed the AOD workforce to see how many have lived or living experience? I suspect more than we know, and people don't say anything due to concern about their work status.
I think that that's absolutely true. I mean, the best that we can do with that is to really work hard to maintain anonymity and confidentiality when we're doing surveys like this. But absolutely, I think that probably the figures are higher than we are finding in surveys like this. I should also note that when we asked the question, it's also kind of left to interpretation as to what lived experience means. And so we cannot be sure from this data exactly how people are interpreting lived experience. Then it might be really different for different people. So I mean, as Marina said at the beginning, I'm come from an anthropology background. I think it would actually be really excellent to do some really strong qualitative work around this, and to interview people about different types of lived experience and how that's actually impacting on their work.
Fantastic. All right, so I have got a couple more, so hang in there. Any that we don't get to answer, of course, that please send through an email. So I've got the details up on the screen there, but we'll try and get through them. So next one in from Shark, actually. So in terms of specific wellbeing support, you mentioned physical wellbeing needing additional support. Any ideas or examples of what additional supports could be provided for this by organisations to LLE workers?
That's a really good one. Look, I think that this is actually an example of, as I was just saying before, that I think a lot of this needs really further investigation, and that we need to do some more targeted work. I mean, it sounds really kind of flippant to say, oh, just have more, because stress, of course, was higher as well in the data that I showed, or stress was a bit higher, but burnout was significantly such. It sounds flippant to kind of go, oh, make sure that there's like yoga available and things like that. But I think that we're probably talking about some more fundamental, maybe chronic disease issues, potentially, but this is not backed up by data, but potentially, issues with, chronic disease issues and related to, for instance, hepatitis C, and other related infections. So I think that the answer to the question is probably that we don't know enough about it. I couldn't tell you exactly what sort of workplace interventions that we would have around physical well-being, but I suspect that it would be some of those things, like around chronic diseases and like viral hepatitis. Yeah.
Thank you, Anke. Okay, so I've got one actually that's following on from Isabella's question about with lived experience and how that could affect them working, people working. So to follow on from Isabella's question, more than a comment than a question, I'm wondering about managers and employers having lived a living experience too. There are different reasons why LLE at management level might not disclose. Something to think about. So that's from Britt at HR Vic.
I agree. And in addition to that, I think that there are also, people with lived, so this is just anecdotal, like from people I know who actually choose to go more into administrative roles in alcohol and other drugs because of their lived experience. So because of the vicarious trauma that they're concerned about, they will specifically go more into admin or research roles and things like that by choice, because of their lived experience as well. But I agree. I think there's very particular issues at that level around disclosure as well. Yeah.
Okay. So then we also have, how would service users help those who have experience with complex trauma and abuse?
How would service users?
How would service users help those? So how would using the service help people who have experienced complex trauma? We might actually leave that one for a little bit later because I think we kind of need a little bit more information. I'm just going to go on to another question. So whoever's asked that question, we will get back to you. I have got, is there any feedback from peer workers about what kind of training they found most useful and important for them to have prepared to become peer workers? Great question.
That's a really, really good question. I'm afraid I'm not in a super good position to answer that question, but I can do so just based on what I know through my interactions with Karma. So that's really, in terms of peer workers, that's really the Canberra Alliance for Harm Minimisation and Advocacy's kind of sphere, not mine. But I do know that, so ATODA offers, we offer a qualification strategy, and we offer training through a qualification strategy, and offer training to get people through the Cert 4 in AOD. And I know that when we've had peer workers involved in that training, that it's often not fit for purpose for the type of work that they do, and that there's a whole range of other skills that they, really need that aren't provided in the AOD skill set. And it includes, lots more practical harm reduction work. It includes, I think that peers in particular are, can experience vicarious trauma through their work, and that there's some very particular needs of the peer workforce. So I definitely know that there are some very particular things. What they exactly are, I'm not the best person to answer that question.
Okay, we've just got a couple more, and we might have to sort of run out of time. So I've got one. Thank you for your presentation. I have a question. Many counsellors and AOD workers have been addicted to tobacco. So is that included in any research? I am asking as even though the experience of dependence on and withdrawal from tobacco may be different to other substance use, a person who's smoked in the past may have a lived experience of craving and go to great lengths to find tobacco and use it.
Yes, look, great question. For people who are here who know me, I actually come from a tobacco research background, so I'm very, very interested in tobacco. And I think that definitely that there are some, even though you're right, tobacco is sort of a slightly different, kettle of fish in terms of how it is dealt with in the treatment context, that I think that it certainly provides, people who've had have had or have dependence on nicotine can completely, understand other types of dependence and can apply that to their practice. I know that there's been a fair bit of work done in the space of how a worker's nicotine dependence affects their confidence or their feeling that they're capable in working with people on nicotine dependence. And there's been a bit of work done. And for some people, that actually makes it easier for them to do it, and for some people, it makes it more difficult. But there's definitely parallels there, and I think that understanding of any kind of dependency can help in the treatment of dependence, of different types of dependence. Yeah.
Okay, fantastic, Anke. Thank you so much. We might just leave it there. So anybody, I've just got a bit of, I've got an interesting comment here, and then we might have to leave it there. So if we have not answered your questions, we will get to those. Also, make sure that you click on the QR code. We've got Marion finishing off the session in a minute. So just one more comment from Steve. OHV has generally valued the LLE members of their workforce, but it's only recently that they've been more proactive in wanting to find out how they can better support their LLE staff and enhance the experience of their experiences. Government funding has helped. Some of our newer initiatives are in provision of clinical supervision by supervisors with lived experience, if requested, and mentoring for new LLE staff at our therapeutic communities. So, yeah, definitely great support there.
That sounds excellent. That sounds like exactly what we need.
Right. And so on that note, that positive note, all right, thank you so much, Anke, for presenting today. It was a fantastic presentation, and thank you to everyone for coming along today, and we look forward to having you on again. Thanks. Bye.
Thank you. Bye-bye.